Our next speaker is Ashley Carnes. She's going to be talking about speech language pathology and role in geriatric care. There's her bio. She's with the Center for Audiology and Speech Pathology here at UTMB. She graduated from Baylor University, so that maybe that room looks familiar. With a master's in communication science and disorders and a clinical fellowship in Conroe, Texas, in speech language pathology. She's a BOI, Galveston native. Decided to advance a career by joining UTMB's here in August 2012. She evaluates and treats patients of all ages with primary focus in the adult acute care setting. At UTMB, she served on the Stroke Quality Improvement Committee and participated in the JACO Primary Stroke Center certification process. She continues to serve as a mentor to speech-language pathology residents and helps facilitate support groups for stroke, head, and neck cancer patients. Her clinical interests include head and neck cancer and voice disorders. Ashley.
I was very excited to hear that Baylor was tuning in. I didn't know that beforehand, so that was exciting. I wanted to talk about the speech-language pathology's role in the geriatric care. Just a disclaimer, I'm not a geriatric speech pathologist. I don't specialize in geriatrics, but at UTMB we do have a fairly large geriatric population, and they are part of the patients that I see. Another disclaimer, I didn't realize when I was picking my time for this that it would be after lunch and people would be sleepy. So hopefully we can keep it interesting enough that you don't get too tired. Again, just a review of the objectives. So what is a speech-language pathologist? Just kind of to open it up, a lot of people have a lot of different ideas. Society generally thinks of the speech therapist who works with the kid on their R's or on their lisp. I lived with my grandparents during graduate school, and they thought I was a doctor. They were like, "You put scopes in people's noses? That doesn't sound like speech therapy." My friends don't really understand what I do. They don't understand that I could test somebody swallowing. They think I just feed people all day. I like to think that I have a pretty important job. You know, I like to think that I'm making a difference in people's lives, maybe not quite as big as the King's Speech. My patients and probably doctors see me as the person who comes up and puts the NPO sign on people's doors and tells them that they can't eat or drink anything. And of course, as clinicians, we all do a lot of paperwork, is a big chunk of our time. But in reality, a speech-language pathologist has a minimum of a master's degree. You can obtain a speech-language pathology assistant position after a bachelor's, but they are generally not found in the medical setting. We specialize in the evaluation and treatment of speech, language, cognitive communication, voice, and swallowing disorders. We can work in various settings, including early childhood intervention, schools, private clinics, hospitals, nursing homes, rehabilitation facilities, and home health. Usually, a speech-language pathologist specializes in a certain population, setting, or a disorder. As you can see, it's very broad. But often in the medical setting, we cross-train in many different areas, especially in a hospital similar to UTMB, where I might feed a baby in the pediatric unit in the morning. I might see an outpatient for head and neck cancer. I might run over and see a TDCJ prisoner patient who had a stroke, and then I'm going to come back over to the acute care setting and see somebody in the ACE unit. So in the medical setting, we do kind of wear a lot of different hats. Consults to speech pathology are generally driven by the physician and or at the suggestion of other members of the healthcare team. And I would say in the ACE unit here, nurses are wonderful about recognizing when a patient might need a speech pathology consult. So I'm going to just go over today the main areas that we evaluate and treat in the geriatric population. But I'm definitely going to focus the most on dysphagia, as that is, based on my rough estimate, 95% of what we work with in the ACE unit. So just a little information about dysphagia. Dysphagia is difficulty swallowing. Swallowing is a lot more complicated than we think of it. You don't think about swallowing as a process that your body is carrying out. You just are eating and it goes down and it's nothing you think about. But I believe in graduate school we learned 17 steps to swallowing. It's a dynamic process that involves coordinated effort of 3 or 4 phases, depending on how many you're counting. And it's driven by the proper sequencing of openings and valves. So it takes a lot more work than we really think it does. So looking for signs and symptoms of dysphagia would be coughing before, during, or after a swallow, multiple swallows per bolus or per bite of food or sip of liquid, food remaining in the food or mouth after swallowing, sometimes we call it pocketing. A wet or gurgly vocal quality is a big one that indicates that they don't have poor secretion management. They probably have a lot of their saliva in their mouth and in their throat. Nasal regurgitation of food or liquid, frequent throat clearing, choking, complaints of food sticking or a lump in the throat, undesired weight loss, drooling, fatigue when eating or drinking, or if they feel that chewing is effortful or difficult, and again, inability to handle their own secretions. It can be that it's wet and gurgly in their mouth or throat, or it could be that they're drooling. So just some risk factors and contributors to dysphagia. If somebody has had a stroke, dementia, progressive neurologic diseases like Parkinson's or multiple sclerosis, myasthenia gravis, immunodeficiency, frailty, limited mobility, respiratory or pulmonary diseases, or just respiratory complications, medication effects, and a history of radiation therapy for oral and pharyngeal laryngeal cancer. And I added that one in there just because of a patient that I saw recently who's 89, 91-year-old man, but doing fairly well, recently developed a pretty severe dysphagia. And looking back, we realized that he had had laryngeal cancer 19 years ago. And you think, how does that happen so late in the game? And radiation can have effects anywhere from 2 to 20 years later. And so he, unfortunately, is aspirating all consistencies, had to move to non-oral nutrition, and that was something that you might not would have thought because it had happened so long ago. So complications of dysphagia, obviously malnutrition, dehydration, and then possibly pneumonia or infection, which can also lead to mechanical ventilation or death. So there are some normal changes that happen as we age to the swallow function. Of course, we have worse dentition, we're losing teeth. Sometimes our patients are completely edentulous. Sometimes they use dentures. Sometimes they say they just gum up their food and they don't need their dentures. They have reduced smell, reduced taste. The duration of the swallow increases, so they have slightly prolonged oral and pharyngeal transit time, meaning that the time that the food is in their mouth, it takes a little bit longer for them to chew it and to manipulate it. It takes a little longer to get to the esophagus. Their tongue pressure declines. There's a slight increase in oral and pharyngeal residue, so food staying in the mouth or in the throat. There's increased frequency of penetration, not aspiration. Slightly decreased laryngeal movement, reduced tone in the pharynx, reduced flexibility of the cricopharyngeal opening, reduced esophageal motility, and degenerative osteophytes, which would be bony growths on their spine that kind of protrude into the pharynx area. All of these things can contribute to dysphagia, but it does not necessarily lead to a dysphagia, and it does not indicate that they have dysphagia. Just because somebody does not have teeth does not mean that they have a dysphagia. So you're thinking now, and again, I'm thinking more geared towards physicians, but this can also be geared towards nurses. You're thinking, okay, my patient has dysphagia, what do I do? A lot of times on the ACE unit, we see puree diet with nectar-thick liquids, and I'm thinking, well, where do they get that diet from? While that is Generally, the safest consistencies for a geriatric patient to swallow. It is still important to consult the speech pathology team to make sure, because a lot of times those nectar-thick liquids can give more residue, which actually present at a higher risk for aspiration. So some different options of ways you can go about managing this is you can do the 5-step dysphagia screen, which was created for stroke patients, but it is available to use with any patient. The patient has a known history of dysphagia and no obvious changes in their neurological or swallow function. You can review the records. A lot of times we see these patients over and over every admission, and when we get the reconsult, we say, well, we saw them 2 weeks ago. Did you look at their last note? They haven't had any new changes. You can probably put them on that diet. Decide if the dysphagia may be more esophageal in nature. Do they have a history of GERD or Barrett's esophagus? Reports of globus sensation, that food's sticking or lump in their throat. Sometimes we even get consults that say, patient with nausea and vomiting, please assess swallowing. That does not necessarily mean that they're having trouble getting the food from their mouth to their esophagus. It might just be that they're having trouble keeping it down. So any of those things you might want to consider a GI consult before consulting the speech therapist. If there is a true concern for aspiration, the patient should be made NPO until evaluated by the speech therapist. Again, this is something that I see a lot, concern for aspiration, please assess swallowing. And when I check their diet orders, they have a standing regular diet. So they're continuing to feed this patient even though we're saying we're worried that they're aspirating. We're worried that food or liquid is going down the wrong pipe. We also tend to see NPO accept meds. Patients can aspirate medications just as easily as food. So if there is a true concern for aspiration, they really need to be strictly NPO or nothing by mouth. And then also, if a patient is somnolent or showing significant, clear signs and symptoms of aspiration, they've got that really wet and gurgled voice, they're not alert, it's going to be pretty obvious. My evaluation is not going to tell you a whole lot more information other than, yes, you were right, they can't eat. We would recommend that the team consider placement of alternative means of nutrition or hydration, some sort of enteral or parental feeding. So when do you consult speech pathology? When your patient is alert enough to sit up and eat or drink. You'd be surprised at how many consults we get when the patient is not alert, and we can't really do anything with them. The patient is showing signs or symptoms of aspiration. They have a new onset of a stroke, brain injury, or worsening of their progressive neurological disease. If they were recently extubated, a lot of times their vocal cords won't be coming together and they might not have very good airway protection. Anytime a patient has a tracheostomy tube, there's a higher risk for aspiration. If the patient has a possible pneumonia or infiltrate on the chest x-ray, and if the patient has decreased PO or oral intake and or unwanted weight loss without any other known cause. Our consults can range from one of these reasons to groups of them together, but just kind of gives you a little idea to go off of. So now I'm going to go through kind of our process for evaluating a patient's swallow. In the hospital, the first step is a bedside swallow evaluation. This is where we're able to assess the structure and functions of their lips, tongue, and palate. Look at their teeth. We want to feel their swallow when they are eating and drinking, different consistencies. We feel for their laryngeal elevation. When we swallow, our larynx elevates, and so we want to make sure that their larynx is moving. We determine their clinical signs of aspiration and their need for further assessment. Are they coughing with certain consistencies? Are they wet and gurgled? Are they clearing their throat? All of those kind of signs I've already gone over are part of what we look for in our assessment. It does not definitively rule out aspiration. So a lot of times, if a patient is a silent aspirator, meaning that food or liquid is going down the wrong pipe and they don't have the sensation to cough, this test is not going to rule that out. So we're oftentimes able to determine if a further objective study is needed to definitively rule out aspiration. So one of the objective studies, or the next steps, would be a modified barium swallow study. This is kind of the gold standard for objective swallow assessments for speech pathology. It's a video fluoroscopic study of the oropharyngeal swallow. We work with the radiologist who uses the camera, and we feed the patient foods of various consistencies mixed with barium so that it's able, so that it's radio opaque and we're able to see it on the X-ray. We're able to identify their swallow anatomy and physiology. Do they have any abnormal structures? And then we're able to rule out aspiration or penetration. Penetration meaning that food enters the airway, but it comes back out. It doesn't actually go down the trachea and into the lungs. We're also able to see if the patient is aspirating or having some penetration, if there's any different strategies or techniques, postural changes. A lot of times you might see a patient that we say they need to tuck their chin when they swallow. That might be because that was the postural change that helped them not aspirate. The other option for assessment of swallowing is a fiber optic endoscopic evaluation of swallowing, or FEES. It is a flexible fiber optic endoscope that's passed transnasally in order to obtain a superior view of the pharynx, larynx, and trachea during the swallow. So the patient is fed foods of varying consistencies, often colored with food dye, and that's just to provide contrast with the skin and the larynx. It allows the examiner to directly observe the movement of the food from the back of the mouth through the throat and into the esophagus, or into the airway if they are aspirating. So there's different pros and cons to each of these objective studies that we do. The FEES we are able to do at bedside, and so it is often used with the acutely ill patients in ICU who are not able to transfer to radiology for a study. Also, the modified barium swallow, the seat for it is only a limited size, and if our patient is morbidly obese, they might need the FEES because they won't fit in the modified chair. Also, this study can be untimed. There's no radiation, and so we can feed a patient through an entire meal and assess for fatigue, which can be pretty important with our older population. And then this study also allows us a view of their vocal cords, so we can determine if there is any vocal cord involvement. So let me just to give you some ideas.
Normal swallow tutorial with modified
This is a little silly, but it has some good pictures and information.
These are a variety of substances a patient will ingest during a modified barium swallow study. Here's what the swallowing looks like under X-ray fluoroscopy. And this is what it looks like from the inside using endoscopy.
So that there is the epiglottis. These are the vocal folds, and that's the trachea. The esophagus is at the back here. We don't really see it here. We just know that it opens as the food goes down. And this is in slow motion so that you're getting a full picture. When we swallow, our larynx elevates and our larynx elevates and our epiglottis inverts to help protect the airway, and the esophagus opens up to allow the food or liquid to go down. So you can see the epiglottis fully inverting. So that gave you a picture of a normal swallow on both of those studies. Quickly, I'll just show you a few other examples. This would be what aspiration looks like on a modified barium swallow. You can see the material going into the trachea. This is another little funny video, but I'm going to skip that one for now. And then this video gives a couple of different examples of swallowing impairment seen on a modified barium swallow. So again, here's the mouth. We look for the tongue, the base of the tongue, to push back. That helps push the epiglottis down and invert. It helps clear this vallecula area of residue. Here they're showing aspiration, and the patient did not cough with that aspiration. This patient also has residue or stasis still in their pharynx. Here they're showing just the difference between a thin and a thick liquid. The thick liquid was not aspirated. They're showing just different postural changes. This is a pretty severe swallowing impairment. The patient is not able to swallow at all. He's aspirating everything. Nothing is going down into his esophagus. And this is another thing we see a lot at UTMB is anterior cervical fusions, which also creates quite a big problem with swallowing as it decreases the space in the pharynx. And so a lot of the opening of the esophagus is limited, and therefore a lot of the food and liquid goes down the wrong pipe instead. It's the only other place for it to go. And then I want to show one more towards the end. We are able to assess swallowing with pills as well. Some people do have just specific difficulty with pills, and so we can give them barium pills. Another problem with the modified barium swallow in the geriatric population is a lot of times if these patients are demented, they have an increased oral phase where the food just sits there, or they might have that tongue pumping and they just hold it in their mouth. And we're only able to shoot the fluoro for a limited amount of time, so it can be challenging to capture that. This is what I wanted to show. This patient is having some reflux, or some of it is coming back up, and that's what they're aspirating. Even though they might not have aspirated on the initial swallow, you can also aspirate on reflux. And I wanted to bring that up as I continue later on. I'll talk more about feeding tubes and the pros and cons of those. So here's just kind of another picture of a FEES study. In these first two, you're able to see that the swallowing is delayed. When we swallow, we want the swallow to initiate as the food is entering the throat, right at the back of the mouth. If the food is traveling down any further into the pharynx, it's delayed, and that presents at a higher risk for aspiration as it's getting closer and closer to the airway. Here, you're able to see piriform residue, possibly a delayed swallow to the piriforms. Again, you're seeing these are the vocal cords, this is the trachea. And this patient has penetration with material on the cords. They might have aspirated during that state. It looks like there is aspiration in that picture. And then again, more residue around the sides, a lot of penetration or laryngeal residue. If that's not cleared out while they're swallowing, or if they don't have the sensation to cough and clear it out, the food and liquid can continue to be aspirated after a meal if they have this residue. So this is just kind of the big picture of kind of our overall evaluation plan. We assess for their potential for oral intake. Is the patient able to eat or drink anything safely by mouth? If they're not safe for oral intake, are they safe enough for maybe just small amounts of snacks for pleasure or quality of life? We determine their method of oral intake. Are they safe with a straw? Do they need somebody to squirt it with a syringe because they don't have good tongue movement? This also includes, do they need certain strategies and precautions? Do they need to tuck their chin, etc.? We select their appropriate diet consistency. Do they need thickened liquids or pureed foods or moist foods? We specify their aspiration risk. A lot of times we will recommend a PO diet, but we also note that they are still at risk for aspiration. They might be at a higher risk for aspiration with certain consistencies. So these are all things we specify. And then we determine their candidacy for therapy or compensatory strategies. We don't always recommend therapy for dysphagia, although it is an option if they are a candidate. When we do recommend dysphagia therapy, the goal is always for the patient to safely tolerate the least restrictive diet. We want these patients to be able to eat by mouth. We just would like for it to be safe. And we don't want them to be on a pureed diet with nectar thick liquids for the rest of their life. We want them to have the least restrictive diet. So a lot of times we might focus on strengthening the oral pharyngeal muscles with swallow exercises, improving bolus control and manipulation, including chewing, their ability to hold the food in their mouth, decreasing their delay of their swallow initiation, helping them to swallow quicker or faster, ensuring comprehension and adherence to diet modifications and swallow precautions, so teaching them how to mix their nectar thick liquids or making sure they remember to tuck their chin every time they swallow. We might also work with the dietitian to ensure the patient is meeting their nutrition and hydration needs. Oftentimes the patient might need additional oral supplements or enteral supplements, even if they're safely tolerating a PO diet. So even if they're safe for a diet, they might just not be eating enough, or they might fatigue too quickly to eat a full meal tray, and so they're going to require additional supplements. I wanted to also talk about the importance of oral hygiene. Proper oral hygiene controls microbial and other deposits in the oral cavity. Poor oral hygiene is a prime contributor to pneumonia. Dental plaque consists of approximately 90% bacteria. Our frail patients are more susceptible to inhaling these potentially deadly pathogens, especially if they have dysphagia. So we often stress oral hygiene for everyone, but especially if the patient is NPO and they have poor secretion management. If they're aspirating their own secretions, we want it to at least be clean and free of bacteria to minimize the risk for an infection. We also put our patients on free water protocol frequently. If they're not safe to take a PO diet, we might say you can have ice chips or water, since those do not have any other bacteria in them. But if their mouth is dirty and they're drinking water or eating ice, they're going to carry that right down with it. So you're still thinking, can I feed my patient yet? Once we complete our whole evaluation, we make recommendations just on all of the things we've been talking about. Level of supervision, medication administration if they need their medicines crushed and put in pudding or applesauce, their need for additional support, all of these things. Also, if we recommend non-oral nutrition, we make a prognostic statement. Is this patient going to improve in swallowing, and we want them to have an NG or a Dobhoff tube temporarily while we work on therapy and we can retest it in a week? Or is this patient swallowing not going to improve and they most likely need a more permanent solution like a PEG tube? Special considerations for dysphagia and end of life. Oftentimes when the patient is moving towards end of life or moving towards hospice care, we might think, oh, well, they don't really need any other therapy because it's over and it doesn't matter. but the speech therapist can play a role in helping the patient determine the diet texture with the lowest risk for aspiration. We can help provide swallow strategies or feeding techniques, things that reduce their risk of aspiration. And then, as I was saying, tube feeding does not always improve their physical function, weight gain, or nutritional status or wound healing. A lot of times it's more associated with increased pneumonia and resultant death. It doesn't necessarily prevent aspiration. And thinking back to when on the video when the patient aspirated the material coming back up, patients can still have reflux and sometimes increased reflux from tube feeding, and they can still aspirate that tube feeding, the supplements, as well as their own saliva and secretions. So enough about swallowing. Now that your patient isn't hungry and he's getting his medication, what else can a speech pathologist do? Looking at assessment of speech, language, and cognition. For speech and language, we look at their oral motor structure and function, their receptive language, which includes auditory and reading comprehension, their expressive language, verbal and written expression, their speech intelligibility, their pragmatics, or their social skills, their ability to read those social cues. And then we really look at their mode and functionality of their current communication system. A patient might not be talking, but they may be communicating fairly effectively or fairly functionally. And we want to look at, are they able to gesture, are they pointing, are they using their facial expressions, and determine how functional it is. When we assess cognitive communication skills, we look at their level of alertness, their orientation, their attention or distractibility, their problem solving, judgment, safety awareness, and their memory. During our evaluations, we also probe for stimulability with cues and the use of compensatory strategies. We look to see, can they benefit from external aids or communication devices? Are they able to gesture? Looking at their prognosis, what will we be able to do? So aphasia is one of the disorders that we would be evaluating. It occurs when there is damage to the language centers of the brain, which for most people are in the left hemisphere of the brain. According to the National Aphasia Association, approximately 80,000 individuals acquire aphasia each year from strokes. Roughly 1 million people in the United States currently have aphasia. Aphasia is divided into two main types, which you will probably most see in the charts, either expressive or receptive, or maybe it's fluent or non-fluent aphasia. But there are 5 to 8 subtypes, and they may affect one or more of the following: expressive language, receptive language, reading, and writing. Almost always they affect 2 or more of these areas. Very, very rarely, if ever, would it only affect one area. So symptoms of aphasia would be difficulty speaking. They might have trouble finding the right words to say. They might have that, you know what I'm talking about. Oh, that thing, They might have sound or word substitutions, which are called paraphasias. So they might say foon for spoon, or if it's more of a word, is semantically related, they might say something like fork for knife and get those things confused. They might have jargon or nonsense words. Jargon meaning real words but nonsensical, not communicating, or neologisms, kind of made up words. They also might perseverate and get stuck on that one word or one phrase. I think I can, I think, and they just get stuck on it, and you just have to take a break before they can move on. Difficulty understanding, so they might have difficulty following directions or following conversation. They might not have very good yes-no response reliability. Difficulty reading, it could be difficulty just reading aloud, or it could be comprehending what they're actually reading. Difficulty writing, again, it could be forming the letters or copying shapes, or it could be that the letters look perfect, but the grammar and spelling is not there. Aphasia can also affect their ability to gesture, or it might affect their pragmatics or social skills. Again, being able to read facial expressions and use facial expressions or tone of voice and understand the meaning behind it. When we see someone for aphasia treatment, we focus on teaching the patient to make use of their stronger skills, their stronger language skills, to compensate for weaker language skills. A lot of times we give them phonemic or semantic cues. So we give them the first letter, starts with a K. Or semantic cues would be giving them a description. It's used to unlock a door. And that might help cue them to think of the word key. We work on developing strategies to improve functional communication. So maybe they are able to talk a little bit, but they also need to have a pen and paper to be able to write, or a communication board. And then sometimes we can use augmentative and alternative communication devices when there are severe deficits. And these are some examples of communication devices. There are low-tech devices, which would be here, and these are just simple communication boards. That's what you would see most here in the hospital, just simple pictures to help them communicate their basic needs and wants. But if the patient has these prolonged deficits and they have the cognitive ability to use it, we can recommend more high-tech options that are pretty much computers, where it has pre-programmed buttons, phrases, keyboards, where they're able to use it to communicate. And now there are even multiple options using an iPad for communication. Dysarthria is another speech disorder that we work with. It's kind of that term slurred speech. So decreased ability to produce clear, understandable speech. It actually refers to a group of motor speech disorders resulting from disturbances in muscular control over the speech mechanism. Again, it's neurological, and there are 6 different types based on the lesion. So symptoms of dysarthria, again, that's slurred speech or imprecise articulation. Their voice might be breathy, they might get short of breath, muscle weakness of their face, lips, and or tongue. They might have hyper or hyponasality, monotone, where they aren't able to change their pitch, or drooling, strained or strangled voice, or they might speak rapidly. When we see someone for dysarthria therapy, we focus on mostly, I would say 80% of what we focus on is developing the use of compensatory strategies. These strategies can drastically improve someone's speech intelligibility if they're able to use them effectively. Just reducing their speaking rate, pacing, taking extra breaths, having them over-articulate and open their mouth wider, improving their breath support. When you don't have good breath support, you don't have good volume, and no one would be able to understand you if you could speak perfectly otherwise. We might also work on improving strength and range of motion of their oral motor movements. We train the patient and the communication partner to restate or rephrase the message. And again, in severe cases, you might want to use an AAC device. Apraxia of speech is another speech disorder. Different from dysarthria, this does not include any significant muscle weakness. It is just the inability to program, sequence, and execute purposeful gestures or movements on command or in imitation. A lot of times, automatic sequences and emotionally laden words might be preserved. So these patients might be able to say, I'm hungry, I need to use the restroom, okay, that's fine. But when you ask them an open-ended question, they can't plan out the movements to say what they're trying to say. Another big thing to notice is that this often co-occurs with expressive aphasia, and making it more complicated to diagnose and treat the differing speech disorders. Apraxia treatment focuses on repeatedly practicing the formation and pronunciation of sounds and words. We work with rhythms or melodies. We use pre-planned carrier phrases, so saying something like, I sit in a, and that cues them to say chair. that part goes with those rote or automatic phrases. If we can get them to say something that's more automatic, they might be able to carry out the rest of the phrase. We also use multisensory approaches, modeling, watching in a mirror, touching their face while speaking. Cognitive communication deficits is a disorder of communication that does not directly involve the language system. Again, it's neurological. It's more common with the right hemisphere, although you can definitely have deficits after a left hemisphere event. In the elderly or geriatric patient, it usually refers to a progressive dementia that's often irreversible. Deficits can include attention, memory, impulse control, judgment, problem solving, planning, reasoning, sequencing, organization. So these are just some common characteristics. They might have those same decreased word recall skills. They might not be able to think abstractly. Most of the time they're going to require extra time to respond to questions, statements, or commands. Decreased grammar, decreased ability to learn and remember new information. They might have exaggerated personality traits or changes, be disoriented. They might be more distracted, more restless, more agitated. A lot of times they exhibit that fear of being abandoned. So treatment of cognitive communication deficits, if they're due to a new stroke or brain injury, treatment is most likely going to be both restorative and supportive and compensatory. So we're going to work on those tasks to rebuild those neural pathways, as well as teaching them strategies to compensate for their deficits. However, if their deficits are more severe or progressive, the treatment is generally supportive and palliative. So we focus more on developing compensatory strategies and external aids. Things like memory books, helping the family know how to create a safe environment, keeping their messages short and simple, providing choices, and keeping their routines consistent. Lastly, I'll talk a little bit about voice. So again, with a normal adult, our voice changes as we age. Perceptually, the voice sounds softer and weaker, more hoarse, more breathy. It might be a little shaky, and it alters in pitch. It can also be affected by pulmonary changes with decrease in breath support. They might require more frequent breaths if they are getting tired. Voice may become weaker or more strained if they're compensating to prevent loss of air. Actual changes that occur in the larynx would be ossification of cartilages and joints, which may lead to increased stiffness in the larynx, atrophy in vocal folds, might lead to bowing. The male vocal folds become thinner and atrophied, resulting in an increased pitch, whereas the female vocal folds become thickened with an increase in the vibratory mass, and their voice gets deeper. Most voice problems in older adults are either natural changes or they're more pathologic conditions such as infections, inflammatory and autoimmune diseases, neoplasms or cancers, intubation, degenerative neurologic disorders. Parkinson's is a big one that has voice changes. Their voice gets really soft. Vocal fold paralysis, and functional voice disorders. So this is just an example of one of the voice evaluations we can do. It is important to know an otolaryngologist is needed to diagnose specific voice pathologies, but the speech pathologist can perceptually and functionally assess their voice. I'm able to say that this patient does have roughness or a strained vocal quality and they're not able to communicate because of that. But if we need to diagnose something like presbylaryngis or muscle tension dysphonia, we need the otolaryngologist to diagnose that. It can be assessed perceptually and functionally without equipment, so I can see a patient in a room and just do a perceptual evaluation, but a lot of times we also use computerized speech lab for acoustic analysis, and then we also use video stroboscopy, which is an example that you're seeing here. So this would be normal larynx with the vocal folds. They're thin and white. They touch completely when we voice, and they open when we are breathing. These are the arytenoid cartilages. They look healthy. This is someone with presbylaryngeus. The vocal folds are a little thicker and they're slightly bowed, which means air is going to escape as they talk. And that can cause them, again, that vocal fatigue. It can make them sound a little softer or breathier or more hoarse. And then a lot of times they tend to try to overcompensate. If their body feels that they're not getting out a strong voice, they overcompensate, and then their voice becomes very strained. Voice treatment is mostly treating the underlying pathologic cause, if any, usually by the otolaryngologist. If voice therapy is warranted, we focus a lot on vocal hygiene counseling and training, making sure they're drinking plenty of water, getting adequate sleep and nutrition. We work on improving their respiratory efficiency, make sure that they're getting good breath support, breathing deeply, work on relaxation, sometimes even massaging the neck and the throat muscles, and then sometimes improving their glottal adduction or the coming together of their vocal cords. So for speech language cognitive disorders, again, you want to consult when the patient is alert enough to participate. If they have a new onset of a stroke, brain injury, or worsening progressive neurological disease that it's affecting their ability to communicate. If the patient is having memory problems because of this. If they have difficulty with their voice for communication. And then again, if the patient is in the near of their life and you think the family could benefit from communication strategies, they're having trouble communicating their kind of last needs and wants. In the acute care setting, especially here in the ACE unit, we don't do a lot of communication or cognitive evaluation and treatment. It is something that's available, but generally speaking, we're focused on their dysphagia, being that is what they will need to make sure they're eating and swallowing safely. And then most of these patients are going to a nursing home or some sort of facility where they can receive speech therapy there for those types of problems. But we are available to do that, and sometimes when there's new stroke or brain injury patients that are transferred up to the ACE unit, that's when we do provide these services. So in summary, speech pathology can play a large role in geriatric care, whether a patient is acutely ill or just weak, or if they're nearing the end of their life. And just kind of a special statement, even when a patient is at the end of life, and maybe even more so, he or she deserves the option and opportunity to maximize his or her quality of life, which is often facilitated through quality communication with their loved ones, or just through the pleasure of eating. So thank you very much. Are there any questions?
I have a quick question about our TDC population. Does speech therapy consult over there or play a role with our TDC population here?
Yes, we cover inpatient and outpatient for TDC. We have 2 clinic days where we're doing, one of them is just a swallow study day, and then one is everything else that I've been talking about, even voice disorders, head and neck cancer, all of those things.
Any questions?
Any other questions?
Maybe from Baylor, how much you?
I don't know if that.
No, that's